So loop diuretics, it acts on the thick ascending limb of loop of Henle on the sodium potassium 2 chloride channel, and in Bartter syndrome there is defect in sodium potassium 2 chloride channel. So how this sodium potassium 2 chloride channel handles calcium, we have to discuss that. So normally it pumps out one sodium, pumps in one sodium, one potassium and 2 chloride inside the cell. Now this ROMK channel, that is another channel in the thick ascending limb of loop of Henle, this ROMK channel pumps one potassium out of the cell. Now what happens, there is two positive charge they came and one positive charge moves out. So now there will be one positive charge and two negative charge. So there will be net negative inside the cell. So there will be net negative charge inside the cell and positive charge in the lumen. So there is net negative here, positive charge inside the lumen. There is now a gradient created in between them. In order to balance it, this calcium and magnesium, they are present in lumen. This calcium and magnesium, in order to balance the negative charge, they moves towards the cell, and there is no channel for calcium and magnesium here, so they undergo passive paracellular transport. Now this is the basolateral side. They from the lumen they move through passive paracellular transport. Now they reabsorbed into blood. This is how this channel, sodium potassium 2 chloride channel, handles calcium. It reabsorbs calcium from the lumen into the blood. If now we have given a patient on loop diuretics and if he has Bartter syndrome, this channel is defective, so now there will be no reabsorption of sodium, potassium or 2 chloride. So now there will be no potassium for ROMK channel to pump it out of the cell. So there will be no creation of net negative charge inside the cell or net positive charge outside the cell. This was the gradient which is responsible for pushing of calcium and magnesium into towards the cell, which has later reabsorbed. So now there is no gradient, so there will be no reabsorption of calcium and magnesium. Now this calcium and magnesium will go in urine. That will lead to hypercalciuria and hypermagnesiuria. To hypercalciuria and hypermagnesiuria. So that is the effect of loop diuretics and Bartter syndrome on calcium or magnesium. So now it is called hypocalcemia and hypomagnesemia. We can remember like loop loses calcium. And another few things about Bartter syndrome I have to tell it here. So Bartter syndrome is a autosomal recessive condition. There is defect in sodium potassium 2 chloride channel, and now what will happen, there will be severe salt wasting. Sodium and water will be lost more in urine. That will lead to decrease in intravascular volume. That will lead to RAS activation, renin-angiotensin system activation, that is prostaglandins mediated. There will be RAS activation. When there will be RAS activation, aldosterone will be released. What is the function of aldosterone? Aldosterone moves out in sodium and water and excretes potassium and H plus ion into the urine. That will lead to hypokalemia, alkalosis, hypercalciuria, hypermagnesiuria, and this is the picture of Bartter syndrome: hypokalemia, alkalosis, hypercalciuria, hypermagnesiuria. Now this hypercalciuria, if the Bartter syndrome patient he has hypercalciuria, there will be more calcium in the urine. It is more prone to stones. If a patient is chronically on loop diuretics like furosemide, he is also prone to develop renal stones, and there will be loss of magnesium also. Now there are various types of Bartter syndrome. So type 1 Bartter syndrome, type 2 Bartter syndrome. So there are various types of Bartter syndrome. So in type 1 Bartter syndrome, there is mutation of this channel, sodium potassium 2 chloride channel. It is present as a neonate, or it can present in the, you can know it from maternal polyhydramnios. If a mother has polyhydramnios, after ruling out all the common causes, you have to look for Bartter. If polyhydramnios means there is increase in amniotic fluid. So amniotic fluid is formed by mainly after sometimes, that is found by the fetal urine. The amniotic fluid is majorly formed by fetal urine after 12 weeks, I think. It is formed by fetal urine. Now this fetus which has Bartter syndrome, he will urinate more. There will be increased fetal urination. That will lead to increase in amniotic fluid volume. That will lead to polyhydramnios. So Bartter syndrome type 1 is seen in children and presents in maternal polyhydramnios. You have to ruling out after all the common causes of polyhydramnios. We have to look for this. So in type 2 it is also seen in children. There is in type 2 Bartter there is defect in this channel, the ROMK channel. Okay. In type 3 it is called classical Bartter. In type 3 it is called classical Bartter. In classical Bartter there is another thing that now it has another channel here. The thick ascending limb of loop of Henle. These cells have another receptor here that is for chloride. That is called CLCKB. This is also essential for proper function of this sodium potassium 2 chloride channel. Now in Bartter type 3 there is mutation of this CLCKB chloride channel. Okay, this is called classic blood Bartter syndrome. And type 4 there is mutation of Bartin, and there will be severe sensor neural hearing loss present with the SNHL. And type 5 Bartter there will be gain of function mutation of CaSR. I have to discuss in more. CaSR is calcium sensing receptor. CaSR is calcium sensing receptor. It located in the parathyroid gland and is also located in the thick ascending limb of loop of Henle. So CaSR maintains the calcium level in our body. Suppose there is hypercalcemia. Now this CaSR gets stimulated. CaSR gets stimulates. Now it inhibits parathyroid gland. And then there will be decreased secretion of PTH. So there will be hypocalcemia that will balance this hypercalcemia, which is trigger for CaSR. Okay, another thing is that it's also present in the thick ascending limb of loop of Henle. It is always CaSR. Remember, it has always inhibitory functions. It inhibits parathyroid gland to decrease the secretion of PTH in the parathyroid gland, and in thick ascending limb of loop of Henle there will be absorption of calcium and magnesium via this sodium potassium 2 chloride and ROMK. They act together to absorb calcium and magnesium into the cell. Now this CaSR also inhibits ROMK channel, and it also inhibits sodium potassium 2 chloride channel. Okay, this inhibits this both channels CaSR. That will lead to increase of calcium loss in urine. That will lead to hypercalciuria and hypocalcemia. So when there is hypercalcemia or increased calcium in the blood, this CaSR decreases PTH secretion, and that will lead to decreased blood calcium level, and it increases the calcium excretion of calcium in urine. So this is the function of CaSR. So if there is gain of function mutation of CaSR, that will lead to hypocalcemia, because if this function of CaSR is now it is gain of function mutation, it acts more aggressively, so it will inhibit more PTH. That will lead to hypocalcemia, and it will inhibit more ROMK, and in case that will lead to hypercalciuria. So if gain of function mutation of CaSR, that will lead to hypocalcemia and hypercalciuria. Okay, so there will be decreased PTH secretion, decreased renal calcium reabsorption, more calcium is lost in urine. That will lead to hypocalcemia and hypercalciuria. Now if there is loss of function mutation, now this CaSR has lost its function. Its function was to regulate calcium by inhibiting PTH release and increasing calcium excretion in urine. Now it has lost in function. Now what will happen? If CaSR has lost its function, there will be increased PTH secretion, because there is no one to inhibit PTH, and increased renal reabsorption of calcium. Okay, now there is increased PTH secretion, that will lead to hypercalcemia, and increased renal reabsorption of calcium, that will also lead to hypercalcemia and hypocalciuria. Now there is more calcium in blood but less calcium in urine. So this is called familial. This is if there is loss of function mutation of CaSR, this is called familial hypocalciuric hypercalcemia. Familiar hypocalciuric hypercalcemia. This is due to loss of function mutation of CaSR. So this is all about CaSR, how CaSR maintains all these things.